friends in the US and Canada and in the Americas. Late good evening to those in Europe, and a very good morning to those in Asia. And as you come over to Australia and Eastern Asia, a good morning to all those who've been able to join us. Today, we are doing something a little different from previous Virtual Global Spine, but not outside our theme of what we often do. And I have with me today Beau Standish, and Beau is a really clever guy. Like he's here with up here with the neurosurgeons, and I'm down here with the orthopedic surgeons. Beau's actually got a proper PhD, so he's a proper doctor from the University of Toronto. And he's got extensive experience in medical imaging. He's also been an assistant professor of electrical and computer engineering. And I think it was working in medical biophysics. Is that right, Beau?
That's right.
That has sort of led him into some pretty significant innovations in the spine area. Ali and I were just talking about this before the meeting started. This meeting is very much not an industry-sponsored meeting in any way. Beau is in the industry, but I have no conflicts with his current company or the previous company before it was sold. Just actually really like the technology, and I think it's good for him to have a chat about how things go from that sort of academic concept and the basic science to ending up with us in the OR and helping our patients. So I will now hand over to Beau, and please feel free to ask questions. And we've got Ali and our other panelists will join us shortly, fire things through the chat box, and we'll ask as we go along. Thank you.
Excellent. Well, thanks so much for that introduction, and we'll get the presentation started here. Just before I begin, Dr. Selby, can you confirm that you can see that?
I can. It's working well.
Just one away. 1 second, there's one away from me.
Coming back again.
There we go.
There it goes.
You figure the tech guy should be able to figure out Zoom after all these years of the virtual meeting. So thanks so much, everyone, for the opportunity to talk about the C-spine Flash system. And as Dr. Selby mentioned, I come from academia and industry. So historically, I was a professor. I did my PhD in the hospital ecosystem. I'm actually from a unique program in the Faculty of Medicine at the University of Toronto, where it turns out I hate blood. So I didn't decide to go on to do anything to do with an MD, but I just have such a passion for medicine that I want to design technologies for my friends and my colleagues. So let's jump into what the Flash system is. And I'm going to share part of that journey of how do you take that jump or make that jump from academia to a commercial product. So let's jump into this. So first off, we're now part of actually, we just finished a merger. We're now called Orthofix C-Spine. Our new corporate name will be announced shortly. But everything we do, and historically, that is part of my passion as well, is how do we transform the surgical procedure at all points during the procedure itself and allow the surgeon to make real-time decisions that have a beneficial outcome on that patient's healing. So here at our current company, everything from enabling technologies like the Flash system to orthobiologics, spine implants, fixation, and the merger of all of those. Focusing for today on the enabling technologies and the 7D Flash system, why would we want to invest time in creating a new technology? Well, the fact is we've been working on it for a while, and we identified a big need. As I mentioned, we had that background in medicine and engineering at the same time, and we identified this image as the big opportunity when we started our journey. Here's an axial image, which is showing a tool and that relationship of the tool as it is cannulating the pedicle. But we felt there had to be better ways to yield this ultimate solution to our surgeon colleagues. Currently, even now, we feel there's too much radiation with all navigation technologies. There can be challenging workflows, adding tens of minutes, where my mantra is, let's be an assistive technology to reduce surgical workflows. Too expensive, especially with robotics platforms, looking at close to $2 million now to cannulate a pedicle. And then there's a lot of global registrations that aren't tracking intraoperative patient movement. So we saw that as an accuracy concern. And we felt that there was a big need and opportunity for a new vision of what spinal navigation can be. And our background is in this area called machine vision, and that's our contribution to the market as a whole. Now, machine vision isn't exactly a consumer level phrase yet, but I guarantee you all are familiar with what that technology can do. On the left-hand side here, we see a self-driving vehicle. On the periphery of the cameras, those cameras are constantly interrogating the surroundings, looking for cars, pedestrians crossing the road, speed signs. Well, we thought the technology had evolved enough that we could apply it to medicine. So in our imaging head, and there on the right-hand side, we now have created our own proprietary 3D imaging system with intelligent software that understands what it's looking at. And rather than looking and understanding if a pedestrian's crossing a road, we're identifying anatomy automatically. What is a spinous process? What is soft tissue? What is bone? And we've taken a registration process that historically can take tens of minutes, requiring intraoperative linkage to a O-arm or to an intraoperative CT system, and based it all on visible light. Now, as you can imagine, a leap forward in technology like this yields an overnight success story. And I'd love to say that that is how media portrays all of these innovations, that you have the idea and then you're all of a sudden drinking a pina colada on a beach the next week. Well, we're an overnight success story 10 plus years in the making. We started this over a decade ago in that academic realm. I'm going to walk you through a little bit of how we got to the commercial product itself. You understood the why, so we really worked through the business case from day one. We didn't want to create an invention without an ultimate clinical utilization, so we started with that problem statement. And in the early years, it is prototyping 101. Left-hand side here, over a decade ago, we're using off-the-shelf computers, trying to create this 3D vision system, using projectors we borrowed just from the boardrooms that we had access to, and starting to create some underlying software for all of this technology to work together. This continued to work, where the ultimate goal here for our technology, think back to 3D imaging quickly and understanding what is in that image so the software can automatically compute registrations. Here now we're in 2013, starting some of our first cadaver work. You can see that the cameras are starting to go into that over top point of view, looking down on the patient's anatomy. Part of that design decision was that our system, we realized, looking at the competitive, everything on the market, even now outside of us, requires 1, 2, or even 3 additional support personnel to help operate the equipment. By moving ours into that overhead light fixture, the surgeon can control everything sterilely. And here we can see those cameras starting to go onto that top point of view. Moving forward a little bit more, since we are now in the top-down look on the patient's anatomy, we're taking up OR real estate, the lights. We needed to create our own 3-dimensional, or I should say intraoperative lighting system. So here's some early images, again, off the shelf. Literally, those days, shows you how long ago it was going to like a Radio Shack to getting some of these electronic components to create the initial synchronization boards and the optics to create those surgical lighting plus 3D imaging. 3D printing became quite usable in 2014, 2013. So all of our early prototypes now starting to make our own surgical light form factors. You can see here we have lights embedded inside of the system. We have trackers, we have different computer boards. For those of you who are garage techies, you might even be able to spot things like an Arduino controller that are very common today, and Texas Instrument control boards. So really, first principles prove that the technology works from a very primitive technical state. That all turned in 2014 March into our first clinical demonstration, where we were able to show we could take those instantaneous 3D images. The software understood what it was looking at, and that data was automatically registered to a preoperative data set, in this case, a preoperative CT. And it was at that time that we made that decision, while we were professors of researchers, to take the huge leap and trust and bet on ourselves. And I went out and raised the proceeds required to bring an academic prototype out to market. And we left the comfort of being in academia and turning this product into a commercial success. And now look at the year here, 2014. Once we started to get to a manufacturable product, took just over 2 years. And it's really amazing the success and the excitement you have of, wow, it worked in 2014 on a patient, but an academic prototype is so different than what's required to just turn on and work every day in an operating room for 5, 6, 7 years, day in, day out, with an efficient workflow that can also be manufactured at a cost that makes the product profitable. Earlier on, we also thought we would start with just a minimum viable product of a tracked awl and a tracked probe for the navigation system. And we quickly realized the number of procedures required many different types of both software modules. So here's now the commercial product. We have 3 different main software applications: open or mini open spine, percutaneous MIS, cranial. And there's 7 different tracked trays here, but I think we're actually up over 10 to support that wide range of procedures that are being used with our system, both in many different types of spine procedures. And we're pleased to announce that a couple years, as we've invested so much time, we just released and announced our 100th placement globally of our Flash system in areas. The 100th unit was going into the States, but now we're in Australia, New Zealand, Singapore, Latin America, Europe. We're all over the place. So switching back a little bit to the technology, and I know Dr. Selby is going to talk about this in detail with his clinical experience. Here's one of those examples of the 3D images that we acquire in about 3/4 of a second. The optical cameras take that image, and that image, it looks like a solid image, but it's made up of over 1 million data points that the software can understand what it's looking at. And this is created using visible light. Leveraging the machine vision concept, a couple of our features that we've released over the last couple of years, really pushing the technology with features that nothing else, no other technology has on the market. The left-hand side, the Flash Fix. What happens if something moves to the reference frame? Well, we knew that from firsthand. That's the most emotional component of any navigated procedure, because you have to make the decision: do I bring in the O-arm back in? Do I redo the point match registration, exposing more radiation? Well, with ours, using the visible light, we can regain that tracking accuracy in under 10 seconds, because we're constantly digitizing in 3D the patient's anatomy. Further into the deformity market, where we're growing quite quickly in the adult and pediatric. Here's a deformity, a scoliotic case, and when you're looking at the radiological views, looking at the axial sagittal, a lot of times those images can be very hard to interpret because of the curvature of the spine. Well, we allow real-time reslicing in the operating room so you can regain an axial or sagittal type look. And finally, on the right-hand side here, we are using augmented reality. We're now starting to do things like our virtual K-wire of showing the K-wire via an animation laid on top of our video feeds that are displayed on the monitor for our surgeon to use, all powered by machine vision. This is going to be a big future part of where we're taking the technology. To maintain clinical utilization, and one thing we believe in is that we're not limiting utilization to only use our implants with our system. We are vendor agnostic, and as such, we have to provide the ability to mate with any type of screwdriver, any type of tap, any sort of instrument you can use intraoperatively. And we've now just released our most updated software, which includes preoperative planning, things like screw planning, both generic and our own, along with disc space measurements for inner body investigation. Finishing up here on the research side, coming out from one of our other Australian colleagues with Dr. Malham, showing compared to existing navigation systems, we reduced radiation in this study by over 96%. So massive, massive reductions for the patient, the operating room staff, and the surgeons. Because our procedures are quite quick as well, saving time in the OR, the study coming out of Singapore is showing on average, and this is over in 100 pediatric patients, we're reducing blood loss by 44%. So huge clinical outputs and beneficial for our surgeons and the patients they serve. And finally, looking at the setup time intraoperatively, this was from before we had access to any robotic comparisons, but looking at an intraoperative CT-based system, think of your OR or Aero CT, we're 15 times faster. So really, when you're ready to use the system, it is there for your use without disrupting your workflow, with my vision of, again, being an assistive technology, not disrupting that workflow, but trying to save radiation and improve your decision-making ability, lowering the cognitive load of what you're trying to do with that instrumentation. So that is my quick overview of the Flash system. I am here for the entire event. Love to field any questions either in the chat or through Dr. Selby and his colleagues, and I'll pass it back over so the presentation can continue from the clinical side.
Beau, thank you so much. I've got already one question on the chat. Within a few minutes, Dr. Du has already asked, can we buy this in China? So are you distributing in China yet? And I think that's one of the issues with all these technologies is actually, getting them to work worldwide, and then, pricing and other things obviously becomes an issue, and maybe not so much for Dr. Du, but we've got colleagues from all over the world that do work in areas which can't afford this type of stuff, basically, and that's always a challenge, right? And I mean, is there so I'll let you answer the question on China, but the further question to that, I suppose, is how do you see this going into the future? Will this be something that will become, like widescreen TVs, much cheaper and more available to those in lower socioeconomic countries?
So one of the really exciting things that allows me to visualize where we can make this really a technology of standard across the globe is that because for the open procedures and mini open procedures, we require no intraoperative O-arm. So right off the bat, we are 2 to 3 times less expensive than those competitive technologies. So we're in Chile, we're in Latin America, where historically they've required very low price points. We have our first system in Israel. We are actually launching our first system into Hong Kong imminently. So we are looking at those different geographic markets. And one of my mandates, it's balancing the corporate side of making sure we're driving what we need to do as an organization. But my personal passion is I want everyone to be using the technology to reduce radiation while beneficially impacting the patients. And when we think about where the costs are going, there are also newer business models that exist where, for example, if you're using our instrumentation or if you're using our orthobiologics, you have the access to the system if you're going to commit to using a certain amount of the periphery technology at the same time.
Yeah. So it's enabling that way. Look, Ali's got a question in the chat box about the advantages of the technology. I mean, where do you see, you mentioned OARM, Aero, obviously big established platforms. Where do you see that those are still ahead of this type of navigation? Like where are you playing catch up at the moment? And I'm going to touch on that in my talk as well.
I'm the first one to admit we don't have a silver bullet, nor does any enabling technology to provide the support that's required across the entire spectrum. So the way that I approach it, I like to use this stepwise approach, is that you start with the biggest market opportunity, you go to the next one and so forth. And it's just a matter of time. So right now, we do not have indications for use, for example, in a lateral procedure. It's coming, but we can't use it today for that, where our competitors can support that type of cases. The interesting thing, though, the caveat that I'll throw there is for us, that's just engineering hours in the day. However, things like Flash Fix, the virtual augmented reality, to my knowledge, there's no pipeline that will allow them to catch up to us. So we have, in my opinion, a greater leap forward from a technology standpoint, even compared to the large multinationals that have been established in navigation for 20, 30 years.
Yeah. I'm interested by, and I'll ask you this while I've got you here, and we can talk about this in the chat. So, I mean, I obviously use your system a fair bit, and I've got some tips for it and some videos on it all coming up for people that want to start and have a look at it. But the MIS system I have used, and it worked fine, but it did require an intraoperative spin. So it takes us back to, basically anyone else's system. Is there anything in the pipeline to get you around, like using skin topography or anything else? I mean, fluoromerge, I don't know what Ali's experience with this is with robotics, but fluoromerge with a CT is really slow. I find it very slow, frustrating slow. So is there any magic that you can share with us to help us do percutaneous procedures with this, or is that all, as I said, I tried your MIS system, it's fine, but it's basically the same as everyone else's. So
agreed, and it goes back to, I'll make 2 points on that. The first being is providing a solution that allows us to compete just in the baseline of what existing competitive technologies can do. And we can now do that. Now, the concept, you use a great word there called magic. And I'm a huge believer that magic is just science yet to be learned. And so when we think about that magic, we do have elements in the pipeline that would remove both the 2D merge and the intraoperative scan. And the only hint that I'll give there is that when you are using your tube-based approach, if you're using that to look down at the anatomy, you as a surgeon can recognize what you're looking at. We have already trained a system to recognize anything open or surface-based for the MIS. So we believe that we're the best situated to also recognize what is just visible down that particular tube. So it's a big work in progress. It's unknown if we'll be able to achieve it, but I think, quite frankly, we're the best situated to achieve that ultimate goal.
Excellent. Well, no, thank you very much. I think things will keep on flowing through the chat box. I might get into a bit of my talk. Just start sharing my screen. Hopefully I can get this to work. Just take a moment. Ali, do you have any comments at the moment, just while I get this running?
Yeah, absolutely. Thank you, Mike, and thank you, Dr. Standish, for that introduction and a wonderful review of the technology. While the Dr. Selby's slides open up, I had a question on actual intraoperative workflow. How does this system work around, say, you do the initial, say, fixation or pedicle screw fixation using this technology, and then let's say you do releases, osteotomies. There are changes, obviously, in the coronal sagittal plane. How does the technology adapt to those changes? Should you need to utilize it to, for further, nav-assisted work, if you will? Let's say you need more fixation or inner body work. How does that technology adapt to changes in the structure of the anatomy in front of you as you do releases and bony work?
Yeah, I'm gonna talk about that a little bit in my talk, Ali, in terms of you have to plan to retain some bone, and once you've taken all the bone, it becomes hard, basically.
Don't make it easy for him, Mike. Come on now.
But it is, that's where you got to get used to using these systems. It's almost a little different from other systems. Probably the most similar thing this is to is those 3D printed guides. This is almost like a virtual version of a 3D printed guide that you need the bone still there to put it on the top of. That's the I suppose what I call the cheap and cheerful way of replicating this somewhat. Beau, we do have a few tricks for getting around it. If say screws are in, you can get around it. What's your trick? I got a few tricks, but what are yours? I haven't talked to you about this, so I'm interested.
Yeah, so some of them, if we were to look at this, just happen to have a model here, and say we have these are all intact bone, but say we have some material that's removed. Well, if we have access to just one side, we can use just the one side of bone anatomy that still exists to register. Similarly, if we don't have access to a spinous process, we have something called our flex array, where we have different height rods, and these can go into existing screws, like so, leaving the midline open for access to visualizing that bone. When we talk about the tips and tricks, like with any technology or when you're learning any new surgical procedure, we always like to let's start with a case that is well understood, get experience with it, and then adapt to what the surgeon needs. And my job is to try to limit how much the surgeon has to change to adapt to us. And it is that tips and tricks. And the tips and tricks for a 16 level deformity might be different than a C1, C2 fusion.
Yeah. I think those are good points. Look, a bit to discuss. I've got a few cases to talk about. I'll get going. We can talk about some of those little technical points as we move on. So thanks again to Beau. I'm going to move forward. I was talking previously about conflicts, and I actually have a lot of conflicts, design, education, consultant contracts with multiple companies, but I don't have any with 7D and C-spine, which is good. And I suppose that's one reason I felt I could bring Beau along and have a discussion about this today, because it's just something I actually like to use, and I think it is very useful. So this was how I used to practice. This is a 66-year-old female who was wearing a cervical collar for 2 years because of severe left-sided neck pain when upright. This is her bone scan, and she's got a hot facet joint on the left at C1-2. She also had left C2 occipital neuralgia. She's a little bit osteopenic, and she had some short-term relief with facet and nerve root block, which was very good, but her pain quickly recurred. She had an MRI that showed a bit of narrowing around the C2 root and quite severe osteoarthritis of the facet joint. So at the top level here is her first O-arm spin, because she'd failed non-operative management, and I took her to theatre. And sorry, the bottom level is her initial spin, and top level there is the joint. And I'll just run both of these through. So you can see here that she's got really sort of dysplastic anatomy with the ectatic vertebral artery. She's got a very sclerotic C1-2 joint with bone fragments everywhere. And Ali's talked about this, and I'm glad he's here because he likes doing, despite enjoying navigation, C1-2 without navigation, is what I've heard him say previously. Does it with fluoro and palpation, whereas I suppose I always felt the opposite in that I did a lot of freehand screws, and I find this situation very, very difficult with the sclerotic bone, ectatic VA. And so this was an O-arm case, and it's ended up in a good result. This is the construct. She's got a transarticular screw on one side. She's got C1 lateral mass notched via the arch, C2 sort of pars screw dodging that VA, and a little lateral mass screw to allow for that osteopenia. The level below was pretty much ankylosed. So she's done well out to 2 years, and this is a post-op CT scan. I think this was at 9 months post-surgery, and she's completely fused. So that was a good result with the O-arm. And so why would you go away from that? And I suppose that's where I question, is O-arm or aero, which is very similar, the gold standard at the moment. And when you look at what I spend a lot of my time doing, which is complex spine deformity, this is where I find the O-arm is not that helpful. And I come from a background of doing a lot of freehand screws. But when I decided to do navigation, I was initially using the O-arm. It's widely available, can register up to 5 or 6 segments, but you can immediately see from a scan like that, that you see there with the EOS scan, severe scoliosis, that you're probably going to have to do 3, if not 4 spins to navigate this construct that this patient needs from effectively probably T3 to the pelvis. They do have a range of pins and clamps that can be very helpful. And for C1-2 with the O-arm, I still find the vertex clamp, which sits on the Mayfield, very, very helpful because it's actually out of the field. And you can do similar things now with 7D and other systems. But this is the big thing, and Beau talked about this, a bumped clamp or just a brief knock on it means that you have to bring a large piece of machinery in again, and you have to put it around the patient, around your sterile field, and you have to spin it. And that takes time, and it takes radiation. There's a reason that many theaters with O-arms have lead lining. It's to protect the people in the theaters next door. So we do have to be very aware that these things are high radiation emitters, and it's probably not as important to the patient who's having a one-off episode, but to the nursing staff, anesthesia, orderlies, everyone else, and us, it is very important. And there's a space in the OR issue when you're dealing with these big pieces of machinery that not only have the actual imaging acquisition component to it, but also have the stealth navigation screen component to it. You do have to drape it in for the 3D image acquisition. You can leave it in there. But the other thing the O-arm does and other systems do, which is really called, is a block registration. And so they're registering multiple vertebrae at once, and they're not really segmenting them out, which leads to some accuracy issues, particularly when you're dealing with tiny pedicles. And I've been through this with idiopathic scoliosis previously. Because of the block registration, it's really quite subject to movement artifact. And this is where, say, the mobile C1-2, and I suspect that's why Ali likes to go freehand for those, or the flexible idiopathic scoliosis, peaking in the lumbar spine, when you start leaning on it, because of the block registration, it becomes inaccurate. And so when you're trying to hit a 3 millimeter apical pedicle with a 4.5 millimeter screw, it's a challenge, and you really need that accuracy. Radiation in the OR, Beau's talked about this, but it is, to me, less of a concern for the patient that's in there for one episode, but it's a concern for me. You know, I've got colleagues of literally my vintage of orthopedics that have had renal cell cancer. One's had lung cancer and passed away. And we're talking about people in their late 30s and 40s here. You know, I look old, but I'm not that old. So it's something I'm very aware of. And I think reducing radiation for us, our teams, our fellows is really important. And then the thing about the O-arm, though, that is good is you can currently stitch 2D images, or of course you can spin it to check your screws. And so, you know, it does have that multiple utility of a double check. And this is a stitched O-arm image. If you're lucky enough to have an O2 O-arm, I actually bring it in at the end, even of my 7D cases, and I only 3D spin if I'm worried about a screw, but I get long stitched images. 95% of patients never get a spin. We can get long images this way, and you can do that a bunch of different ways: intraoperative CT, aero, etc. So that's what I use. But you know, the question then comes, well, why not freehand or fluoro? And I suppose I've done thousands of screws freehand or MIS fluoroscopic, and we published MIS fluoroscopic case series with high accuracy, about 98%. But we still see errors. They're rare, but they occur. My little Twitter post on the side of your screen there shows one of my colleagues has removed some screws. One of them was pretty clearly breaching the canal. You can still see where the tract was. Fortunately, well, you know, this was cord level and the patient got away with it. But that screw was wholly within the spinal canal at some time. And then we talk about accuracy, and 98% accuracy sounds pretty good. But when you actually break that down to how many screws we're putting in, particularly in spine deformity cases, 98% accuracy still means that about 1 in 4 to 1 in 5 cases, we're going to have a breach. So, you know, is that acceptable in the modern environment, in, you know, medical legal environments like that we work in Australia, the US, and the UK? You know, it's getting harder to justify, even though you warn patients about it. So I think that's another factor, and it's not the sole factor in my decision making. And I certainly be very hesitant to criticize good freehand surgeons for doing what they did. I've done it for years. But this is the other big reason why I like navigation and technology. Is Wendy on yet? I don't know if I've seen her yet. I don't think we've got any other orthopods on here, so I'm going to have to read my wrist MRI for you. But essentially, this is my MRI from about 8 years ago. And even when I was in my 30s, I developed severe osteoarthritis of certain parts of my wrist. And that's a big lot of fluid you see in the distal radial ulnar joint there. And it's not a pretty wrist MRI. So, you know, these doing things by hand and feel is awesome, but it breaks you eventually. That's my experience. And, you know, we shouldn't be so worried about the screws. We're breaking our wrist to get them in that we forget about the important stuff with surgery. So why did I move to 7D? Well, actually, what struck me initially about the system was you actually get a 3D model in the OR, which is kind of cool. It means you don't have to print them out. Now, I know that a lot of companies will print your 3D model now, and 3D printers have become more common. But when they first came out, we'd have to wait 4 to 6 weeks to get them from the US. And so that was a bit, you know, you're sort of waiting, you get your model and then it comes. Now you can get it straight away. 3D screen, you can just manipulate it, do whatever you want with it. And you're not really wasting the plastic or polymer. The biggest thing about 7D is it stops me going into angry Hulk mode when the frame gets bumped. And, you know, frames getting bumped, it happens. You can put your frame in carefully, but you've got residents, fellows moving around you, scrub techs that may or may not be familiar handing you stuff. And I think the ability to re-register quickly with this system dramatically improves it over existing systems. I would definitely say that. It, of course, improves efficiency and workflow. I'll show that in a moment. The ease of re-registration, if it's not right, is the other thing. So not just when it gets bumped the frame, but if it doesn't feel right. Because if you've done a lot of these cases before, you kind of know the entry point, doesn't quite feel, you can just re-register it. Whereas if it doesn't feel right with another system, again, you've got to wheel that big old O-arm back in, spin it, and see how it goes. It segments out the anatomy. We talked about that briefly before. You can actually do dual instrumentation with it now with the KY type marker or the virtual KY. And that also makes it excellent for teaching. So I can literally be putting in a screw at the same time as the my fellow or resident is on the other side. And this is a case we were doing together, just a routine AIS case. But that's Dr. Kantar there on the right of screen. He is my senior resident, who's now a fellow over in Melbourne. That's Holly smiling for the camera, our scrub tech. And that's me putting in the screw while he starts working on the other side. So using this kind of a technology, number one, he's sort of able to get a feel for the pedicle and work his way down in there. But I'm also able to put a screw in the same side, and we're not worried about bumping the frame, because if something bad happens, we can just reflash. So again, another case, and this was a pediatric case, again, working here with one of my neurosurgical colleagues, Dr. Cartwright. And this particular case, there's a lot of type C pedicles. You can see there bottom right at the apex of the curve. And the pedicle on the other side is quite good, but getting through these pedicles is hard freehand. And so I now use the Navigator Beau to get down them, and it makes life really easy. So why wouldn't you use 7D? Well, there certainly is a learning curve. And the first time I used this, I tried to do it on an MIS TLIF. And, it's not an operation I do that much anymore, but I do an MIS TLIF through a little Wiltsy approach before I take the facet out. And I thought, oh, cool, let's check this out. Let's see if I can see down this small hole, see the bone and flash. And it didn't work properly. And it was probably as much user error as, the difficulty the technology has sometimes seeing in a small space. But I had to abandon it. I went back and did a MIS fluoro technique, bilateral facetectomy, my usual old TLIF technique. I don't do too many of them anymore. But my advice is, do not start your 7D experience with a case with just a small amount of exposed bone. You want to do something that you're going to do open, say pelvic fixation or something like that. And the next part to Ali's previous point is you only resect the bone when you're happy with implant placement. Now, ways around that include, if you have to do a wide osteotomy or a wide ponte and the screws heads are going to be in the way, is to actually just put bone wax and a wire down them. And I find wires are very good, so I use a K-wire a lot. But, I know there's downsides to it. And the picture on your screen there shows that when I didn't realize I'd bumped it when I was doing some pelvic fixation, and my first K-wire has skimmed the notch. And then I went to put the screw down. It didn't feel quite right. I took it out, and the K-wire has broken at the tip of the screw in the pelvis. So we spin that patient. So I did use 7D for that. So the two wires have broken there, one for my SI bone and one for the K-wire for my S2AI screw. And so, look, one of the challenges with doing that kind of pelvic fixation is you need to essentially mallet the sacroiliac joint device across the joint. And we're now working on ways to stop that, because when you mallet it in, it does decrease your accuracy. I should have reflashed, but I didn't realize, and I was moving quite quickly. And I only realized when the screw didn't feel quite right going in the SIJ, didn't have quite that grip, that there was a problem. Just checked it on X-ray and found that. Now, we spun that wire. It's just sitting in the bone, completely safe. So left it alone and told the patient about it later. And she's doing fine, so she's very happy. But
Mike,
like the navigation system. Oh yeah, Ali, go for it.
Apologies, sorry to interrupt. Just a quick question, and I think you or certainly Beau can talk about that. But when you mentioned reflash, or something was off, you were malleting, you have to reflash. Can you walk us through that? What does that exactly entail? What's that process of reflashing look like?
Oh, yeah, I've got a video soon, Ali.
Oh, man, you're ahead of me all the time here.
I got a video of reflashing, but essentially it's basically like it's just redoing your registration, but your registration took you 30 seconds, and reflashing is even quicker because you just run the camera again and you don't have to put to the points. It just rechecks everything for you. And sort of, it's amazing. Like, that's why I've got Beau on, because in my head, I still don't know how that works, but it works.
So it's completely, and again, I don't have an engineering background, but it's an optical based acquisition. It's with your OR light. Yeah. You'll see it in the set.
Yeah. Yeah. Look, the MIS module's available. I enjoyed it when I used it, but I wouldn't advise starting with it. Get a bit of experience with the open first. CT is still required for this technique as well. So although the radiation in theater is dramatically reduced, as Beau was saying, you still need a CT scan of the patient beforehand. Not an issue for my adult patients. Pediatrics, we've got the doses right down. You do a low dose CT. It's worth talking to senior people in at 7D and C-spine about how to do that, engaging with your radiology providers. And my hope is that with some existing technology with bone MRI, we'll be able to integrate that in the future. So you can get your MRI for your pediatric idiopathic scoliosis as you would anyway as part of your workup, and that can feed into the system rather than a CT scan. And that would be my preference for those patients. And then, of course, the cost is there as well. And we talked a little bit about that before, but hopefully that'll come down with the passage of time, and it compares favorably to other systems. So look, this is a case that I did early in my 7D experience in some ways, and was in a little bit here, but this I did about 12 months ago, and this one I did all freehand because we got into the OR and the CT didn't load properly into machine, and that was our fault. We'd had liaised with a different radiology provider, and they hadn't quite got the CT in the right format to load into the system. And so I had to go back to old fashioned, and we did this osteotomy freehand, and it went fine. And patients very happy. We only lost motors a little bit, but I can't blame C-spine for that. And they all came back by the end of the case. So this was I think it is, the point is, it is nice to be able to do these surgeries the old fashioned way when you have to. And anytime you're adopting this, it isn't a substitute for being good at the surgery in the traditional way. So this is a case that we've got a few videos of. This is a girl, she's around 15 years of age. She's got a pretty nasty curve. She's got a combination here of actually a bit of Sherman's kyphosis of about 75 degrees and a lumbar scoliosis. So it's not adolescent idiopathic scoliosis, but adolescent spine curvature or deformity. And she's Sanders 4. So she's still got a lot of growth left. And this is not really a braceable curve. With the current magnitude, her EOS side benders, probably a little suboptimal in terms of effort, little flexibility in the lumbar, not much in the thoracic. Her lying imaging showed some flexibility in that thoracic curve. So I'm just going to move forward here just so we get good time for questions, but this is the setup in the OR, and operating there with me is my fellow from Argentina, Sergio. It's not mandatory to have a bad beard in my OR, but I don't know why most of my fellows and residents do. This is us just doing a routine open spine exposure of the thoracic curve. And the setup there. And so this is where we come to the registration. And you can see here.
Better. Just, yeah, that's, you've got to rotate the light to match the spine. So
Beau, can you guys hear me on the video?
Yeah. Yes, we can.
Not bad. Let's have a look.
The light's up there, and we're flashing now. We've got everything open. We've got our clamp on the spinous process.
Right. Looking away. There. When it flashes, try and get your headlight out of it. Okay, number 1 point. Going to be there. Number 2 point on the SP. Number 3, laminar. Wait up. 3, we'll just move it a little bit. Too quick for me, Kieran. Just there. Yep, that's the one. Coming in with 4. 5 is on the left, yep. On the other side. Yep. Move 6 to the mammillary process on the other side. So drag it all the way over to that. Yep, because we'll see that better. It's the high side. Yep, done.
All right, so yeah, this is the registration process. So you can see there, basically the light is not the theatre light, which we've just pushed out of the way. It's the light above my head.
Good amount of clean. On there, we'll get rid of that screw projection. Looks pretty good.
Yeah, so that's that registration is done, and that's for the bottom 2 segments. And when you're operating at the very cranial and caudal end, there are some little tricks you have to use because you want to preserve the midline ligaments a lot there. You can't use the tip of the spinous process. And it is nice to use bone surfaces at multiple levels. So you don't just want to use the laminar, you want to use tip of spinous process or tip of mammillary process. And that gives you your registration there. So yeah, this is just a video of pedicle cannulation and how you can do with workflow. But
that's it.
Like a lot of systems, you can just plan. So you just touch the bone.
See, can we put a 6'5" projection on there? 45, yeah. 45? Yeah.
And I'm doing freehand here, but I use for the tighter pedicles, I use the burr. Just it helps save my wrist. You can use burr all the way if you want, or power tools.
Let's go reverse projection now.
You can see on the scan the Sherman's in her thoracic spine. Yeah, so to get that nice anatomy there.
That's us, thanks.
So
Just
pretty
wait,
routine. And so,
just hide that for a moment. Just hide that for a moment. Just get that.
so you got, yeah, pedicle feeler you can use,
Pretty good.
navigator pedicle
Cool.
feeler. So you've really got all the little tricks there, and then just navigating the screw in. You can choose to navigate the screws, or if you're happy to put them in over a wire, you can do that as well, and that can speed up your workflow a bit. So you've got multiple tools that you can use, like most nav systems, really.
And Mike, this is just a little plug for something you were talking about before, which is, you showed the MRI of your wrist. And I'm glad you said that was a wrist, because I was looking for the pedicle and I couldn't find it. So thank you for telling us neurosurgeons that was a wrist MRI. But for ergonomics, and I think you know this because we've interfaced a lot recently, is I really like the power tools, the power drill, power tap, power screw. That really helps with that rotation and the stress on the different joints. I imagine, although I don't see it in your video here, but I imagine this technology is compatible with the automated and powered instrumentation, powered drivers.
Yeah, so I mean, as Beau was saying, it is, although they have been, 7D was purchased by C-Spine, I think it is kind of neutral in terms of what you can attach it to. And so you can put your power tools on. If you want to use that slow oscillating drill to get through the pedicle, you can do that. Absolutely.
Yep.
So that's an advantage to be able to use those, put everything on power basically, and do that for sure. As I said, I use the burr, and then I still like to put the screw in on freehand because I just like that tactile feedback, but not using the awl to get down those tight spaces has really changed it for me. I've put in probably 65 pedicle screws this week myself, and my wrist isn't sore. And previously I'd be icing it and taking anti-inflammatories and having days off to try to deal with it if I had a week like that. So it has changed a lot for me in terms of this kind of work. But yeah, I've got a couple of other quick videos here.
Oh, yep. Now, can we get?
So this,
yes, you just want to angle up towards the head of it.
This is my fellow Sergio putting a screw in.
Perfect.
And he's had to get the entry point first himself. All right. So I make sure that the fellows and trainees are actually getting the entry point where they would go close and then looking at the screen after that. It's really important. And that's just tapping down.
There we go.
So I've got to watch Sergio because he's going to try and steal this and take it back to Argentina with him when he goes home. But he may be on the call now. So Sergio, don't steal our stuff. You got to buy one down there. And so this is another little video intro of
children Sergio, so you can get this going up.
Actually, this is a super cool part. It speeds me up a lot, right? Because I'm not as adept as working around the dura as my neurosurgical colleagues. I mean, done thousands of laminectomies in the past, but I just want these ponte osteotomies to go really quick. And now I can use the nav burr to basically take down everything to the eggshell of bone and then just come straight across it with a 2.5 or 3 Kerrison. So this is just a brief demonstration of using the navigator burr across the facets for a ponte. And this particular patient, I did about 6 or 7 and got through them within 30 minutes. So ponte osteotomies, they slow you down, they increase your blood loss. So anything you can do to speed up that process helps with your surgery. So this is
so we're a little deep there.
So video of flash fix. So Ali, this is the flash fix we were talking about. So we've gone back to our registration screen. And we've just reflashed via the operating theatre light where it's housed. So I just felt the probe was floating a bit. I wasn't happy with the registration. And that may be because we've pushed on the spine or something else has moved. And then it comes back to this green screen.
Better? Much better. Because we put it through in it, it just started to drift a bit.
Yeah. So when we put a screw in on one side, I had a good grip and it just moved that vertebra a little bit. level above, and then we went back to it and we got our navigation straight back. So that works really well. So that is the fix for inaccurate navigation. You know, it's not respinning. That just took all of about 15 seconds, I think. So it's been a good experience from that perspective.
Very small particles. Let's just get maximum accuracy.
So
So
here,
it's 2 segments for, yes, one segment gives you the most accuracy, but if you've got obscured vision, sometimes it doesn't. So I reckon in general, 2 segments is really accurate. Spine's very stiff. You go 3 segments. Clamp on 10? Yep, clamps on 10. Just wait for it to stop bouncing. Nice. Okay, you ready? Ready.
so this is just a very standard registration.
Now 10 may have to just move down a bit here. Up towards the head, cranial, sorry.
And what we're looking at in that middle is the
Yep.
is the picture of the spine open that the
It's got to get around the
clamp.
clamp.
Mike,
can put the clamp
I
down.
apologize if you covered this. It's not
That's a lot of
evident.
green.
So each time you, let's
Yeah,
say
very
you're,
good there.
you're cannulating or, T7, T8, T9, whatever it is, you basically
What's your plan here,
are you
Kieran?
registering 1 or 2 or 3 segments at a time, and then you're restarting that process for the next 2 or 3 segments?
Yeah, so that was a 2-segment registration there because it was a bit tricky, the anatomy, and you were coming around the corner. So one of the challenges here is that, yeah, if the spine is very curved or kyphotic, as you come over the corner, all systems, I think, do struggle with the clamp relative to that. And so I register 2 to 3 segments standard usually. And that's where it takes a little bit of planning, because at the bottom, seeing the bottom vertebra in this construct, particularly if you preserve midline ligament, can be a little challenging. So keeping them both linked together, say we were fusing to T12, so T11 and 12 doing it at the same time does help the system. But if the spine is very mobile, that's where you can run into trouble. And the one you'll run into trouble with is the most distal one. So it's the very top or bottom of the construct. So I often instrument those or do the cannula run first down those and then bone wax the hole, maybe pop a wire in it, and then do the screws at the level above and then come back and put the screws in that. It's just about working around the clamp, little workflow things. But in a very stiff, say, ankylosed thoracic spine, where it's quite flat or in the one plane, you could do 4 segments at a time here very easily. I have found after about 4 segments, it starts to lose accuracy. Yeah. But because the flash is so quick, you don't, the re-registration is so quick, you don't need to worry about having huge long segments when you do it. So this was that girl's final result. I haven't got an EOS yet because she's only just had her surgery. So she actually ended up having a combined thoracic fusion and a tether. We've got her upper thoracic curve down from about 65 to about 10 degrees. And I've tethered her lumbar curve as well to try to keep a bit of mobility rather than fusing it at L4. So that's a controversial operation and topic for another day, but the technique worked well for her. It's a hybrid fusion tether. And this is another part of the tech, and this goes with robotics, and we've talked about this a lot on this platform previously, but this is screw planning, right? And so it's not just about telling people what you need, it means that you can start getting things out in advance, or as we move towards a world of pre-packaged screws, we can actually have everything ready to go. So that, I mean, I have to, Ali's on, and I don't know if other people can chime in at all, but screws at the moment in Australia, they either come in screw banks or they come pre-packaged individual. Screw banks are awesome, but there is concerns about sterility and, reusing, etc. And I have seen some studies on, the use of bank screws that are continually washed and contamination and potential low-grade infections. So we may be moving towards single-use or single open screws. And as you do that, it's really nice to be able to just plan every single screw and be confident it's going to be accurate. And this system allows you to do that. And this is that a case that I just showed there with our pre-planning. This was a young lady, again, with a combination of Sherman's and scoliosis. And she's had a T2 to L2 instrumentation fusion, a bunch of navigated osteotomies there. So this is another quick case just to show you that this actually works with metal in. So this was a patient that started back in about 2018 with stenosis and a mild DS L3-4, had a laminectomy and decompression at level done with traditional posterolateral implants. She has a bit of psoriatic arthropathy. She actually developed a DJK issue or DJF issue, essentially, so distal junctional failure beneath that with a bone-on-bone disc. She also osteopenic. She fractured around her right hip implant, which I diagnosed when she first saw me about her spine problems. So we had to send her away for a major reconstruction around her hip. This was, you can actually see the hip reconstruction at the bottom of those spine x-rays. When she came back to me, she developed frank instability. You can see the collapse there on the erect x-ray. The MRI shows this fluid cleft in the disc beneath her fusion. She'd also degenerated a level above, L5S1, and her sacroiliac joints were bad. So her revision to me focused on all the areas. That's her ALIF at 4.5 and 5.1, just the 4.5 cage being shown there. They're prone lateral at L2-3. This is just sort of hammering the cage across the prone lateral. Didn't use 7D for that. We may be able to in the future. And this is the 7D nav in the pelvis. You can see how bad her SI joints are. And so you're running pelvic screws in, S2AI is pretty standard. The thing about this is you can plan where you put the screw heads. So you can actually then get extra screws in. And you can see on the bottom right of screen there, you can see her metalwork and how the CT scans dealt with that. And we were able to use that metalwork as a point to navigate off. So this flash system recognizes metal as well, and you can use devices that are already implanted to guide where you put your other devices, which is very clever. In fact, my understanding, and Beau can correct me if I'm wrong, is they recommend you leave the metal in before revision implants rather than taking it out.
That's
fair
right.
to say?
Yeah,
Yep.
we use those as existing fiducials to register off of.
Yeah.
So we really don't suffer from that starburst effect of implanted metal. And in the latest software, you can switch between the registration off of the metal and the anatomy and flip back and forth in that visualization mode.
That's a really nice feature. I've used that a lot. So this is this lady's final x-rays, and she has gone from a sort of, quite a positive sagittal balance with a failing segments above and below her fusion construct to a good overall result so far. So she's been happy and she's solidly fused. You can see her CT cages there. That was an early post-op CT just to show her implants. So that was a potentially tricky case made relatively smooth with the technique and technology. But you can see on her EOS AP that I've been able to get an extra iliac actually, no, I don't think she's got an extra iliac screw. I think she's got an extra rod. Sorry, she hasn't got double iliac on that side, but often do double iliac screws with the technology, because you can stack them and actually get the heads enough away from each other that you can get that done quite easily. So yeah, and this was literally a case I did yesterday. We just took a pic of because I was redoing a broken tether in the thoracic spine, done at St. Elsewhere, but I've got my own. And just using this technology where there are anterior screws already in the thoracic spine to plan our screws posteriorly. So this would be a super challenging case to do freehand, because your pedicle probe, not only trying to get down a tight pedicle, but you're running into implants halfway down the vertebral body. So we managed to instrument all pedicles from T3 to T12 with the exception of 2. Using this technology. So I had a lot of sublaminar bands there as a backup just in case. Didn't need to use any of them. I'll show our films later on LinkedIn and Twitter, but it was a good case. So I literally did that one yesterday. So we've got just a couple of minutes to discuss, but you're welcome to visit South Australia anytime. Have a look at the system. I'm not able to pay for you, but I'm happy to host you. So we'll have to talk to the companies about that. But feel free to come on and see some cases. I do a couple a week at least with this system. So with that, I'll throw it open to the floor, and we'll have a little chat about the system and any other navigation questions. Really happy to take any questions.
Mike, that was really nice. That was a really beautiful demonstration of of not just the technology, but certainly little tricks and pearls of navigation. I think you saw here from Joel Hubner. What is the number of maximum? What's the maximum number of levels that you could register at one time?
Yeah, I think 4, as I was saying, is about the most I do. You may be able to do more, but it's so quick to re-register that it's just easy to just move up and do it. Look, there are little workflow things with doing ponte osteotomies and things like that, but most ponte osteotomies I do, I am able to do just between the screw heads, and you can use the nav for that. Probably don't have to be as accurate for that. So if I put all my screws in and I've come back to do the pontes, that's when I'll tend to register 4 segments at once, just off the lamina, and just use the burr, because I'm doing that under direct vision as well. And I'm just using that as a double check to see how far through the facet joint I am, basically.
Got it. That makes a lot of sense. And if I may, Beau, just a question for you. I think you mentioned that just last month you were able to install your 100th piece of equipment here, which first of all, congratulations. And second of all, are you able to share how many of those are in the United States?
Yeah, so about 60 or so are in the US, and then 40 plus are OUS. So we are growing, and it started out most dominantly US. So we're growing, I would say, this last year faster OUS right now, but they're always neck and neck for the number of units per quarter.
Great, congratulations. Thank you both. Mike, I'll send it back to you as the moderator to close up.
Oh yeah, I'll close. Matthew Burchuck's one quick question. Is this helpful in en-bloc resections in primary spine tumors? The long and short of it is I haven't done one, Matt, with that, but I have done navigated osteotomies with it. So navigated VCRs and PSOs, so very similar, and it's worked beautifully. And the thing about this is if you keep some lamina intact above that, that's going to be connected to the space, you can re-flash on it. So that's the joy of this, is that you'd have to take a video next time I do a PSO with it, but you can keep your accuracy, because as you know, the spine tends to sag as you do your PSO or VCR a bit. Even if you've got a rod in, the anatomy keeps changing. And so as you feel that anatomy changing, you can re-flash to double check your depth with various tools. So absolutely, I think it would be helpful in an en-bloc resection in primary spine tumor. There's a quick question from Gabrielle. Does 7D have training platforms like in VR to make it even more user-friendly for the future trainee? Well, you can always come and see me and watch videos, but Beau, is there 7D training platforms?
So there absolutely is. We looked at the VR technology. Unfortunately, the biggest feedback is it makes people motion sick. So when you have it on too long, so we have entire online databases for training. And one of the best ways we do it is usually at all of the major national conferences. We have representation there where you can use it at cadavers. And what we do a lot as well, like with Dr. Selby, is if you're local, we'll bring you in and let you observe a case and get some hands-on exposure that way.
Well, thank you. I think we're at the top of the hour. I would like to thank you very much for coming on and sharing a bit about your technology journey. And I think we look at the tech in the OR and the journey it takes to get there, and the jump out of a safe academic job into the dog-eat-dog world of medical tech. So congratulations, you've achieved a lot, and thank you for coming on today. I'd like to thank Ali. Alex has just joined us as well, and all our other panelists, as well as all of our guests on today. Next week, Ali, I
got it. Yeah. Hi guys. First of all,
there he is.
Great talk. Yeah. Great talk. I listened to all of it. Great seminar, Mike. Pretty impressive work. Inspirational, actually. Being on the cutting edge of technology is really important. Learning curves to overcome, and frustrations. And so kudos to you doing that. So next week we'll be hosting my junior partner, supreme surgeon, really excellent surgeon, Dr. Najib Al-Tekli. He will be speaking to us about evidence-based spinal surgery. Thank you, everybody.
We need some of that, Nada. Thank you, everyone. Thanks for joining us. Just before we go, I want to thank Kieran McDonald. Big thank you for doing those videos in my OR, and Kieran Ryan for assisting us on that case. you know, that education stuff is something beyond me. He edited all those videos and did a great job. So thanks, Kieran, and we'll see everyone next week. Bye.
Take care, everyone. Have a positive evening or morning. Bye-bye.
Bye.